Good evening. This is Dr. Hassan Salah Kamel, Professor of Obstetrics and Gynecology and Fetal Medicine, with you today from Asyut University. Now we are going to deal with a somewhat difficult subject, which is fetal tumors. This is somewhat difficult because it is really uncommon state that you would meet in your life very few cases, or you may not meet at all. However, fetal tumors is very uncommon or rare. They may malignant fetal tumors, if they occur, can metastasize to other fetal organs and to the placenta, but never to the mother. On the other hand, if the mother have malignancy like leukemia, melanoma, or breast cancer, these can metastasize to the placenta and further to the fetus and its viscera in particular. The incidence of fetal tumor is actually not well known. It's considered in the live births to be about 10 per 100,000 live births. However, because tumors present in fetuses who are stillborn or in abortions are most likely underreported and not included in tumor registries. It's also generally agreed that tumors that would manifest in the first 3 months of postnatal life, these are actually congenital tumors, but usually not included within tumor registries also. Actually, there is no formal classification for fetal tumors. However, they may be classified into solid and cystic. They may be also classified into benign and malignant. They may be classified into teratomas and non-teratomas. And finally, the most accepted way for classification is by location or by system, as in which they would occur. About 2/3 of congenital tumors are teratomas. This is a very important basic figure to know, and that 1/3 of tumors includes a wide variety of tumors like neuroblastoma, leukemia, retinoblastoma, and other tumors. And that neuroblastoma is the most common fetal malignancy. Teratomas, as we have said, represent 2/3 of fetal tumor. They occur typically along the midline of the body, anywhere from the coccyx to pineal gland. Ectodermal components, especially neural tissue, are the dominant feature of these teratomas. Sacrococcygeal teratoma is the commonest type of teratomas. As we have said before, teratomas generally represent 2/3 of fetal tumors, and sacrococcygeal tumors represent about 75% of teratomas. That is to say, in conclusion, that sacrococcygeal teratoma represents about half of fetal tumors. The sacrococcygeal teratoma would have a mortality rate up to 50% when they are diagnosed before 30 weeks gestation. However, this figure drops to 5% if it is discovered in a neonate. The sacrococcygeal teratoma is usually cystic, is usually mixed cystic and solid. However, they can be totally cystic and can be totally solid. They are usually highly vascular with arteriovenous anastomosis, which is reflected on the fetal hemodynamics and is usually related to the features that develop later on because of fetal hyperdynamic circulation, which produces polyhydramnios, fetal hydrops, and this is the main manifestations of sacrococcygeal teratoma appear on the clinical picture of the mother. Finally, fetal anemia and thrombocytopenia may accompany large teratomas. The sacrococcygeal teratoma can be classified according to their situation into 4 types. The first type is mainly external, while the second type is mainly external with small intrapelvic extension. The third type is mainly intrapelvic with a small extrapelvic part of it, while type 4 is totally intrapelvic. This slide shows the different types of sacrococcygeal teratoma. The above row shows us, in the first picture to the left, a totally cystic teratoma, in which some part is outside the pelvis and some part is inside the pelvis. The middle picture above shows a mixed teratoma in which you see both the solid and cystic parts, and also it has some intrapelvic extension, while in the third picture to the right above shows mainly solid teratoma, which is mainly extrapelvic. The first picture below to the left shows a mixed teratoma protruding outside the body, while in the middle picture shows the arteriovenous anastomosis detected by color Doppler examination of this fetus, as the arrow points at, and finally the right picture below shows the appearance of teratoma in the newborn. Sacrococcygeal teratoma may present by fetal hydrops. However, whenever fetal hydrops occurs, this means that arteriovenous shunting is prominent and produced serious hemodynamic effects, and which reached up to fetal heart failure. Fetal hydrops represents a bad prognostic sign whenever it exists with teratoma. Other signs include polyhydramnios and premature delivery and dystocia in labor. When color Doppler assessment is done, actually it is of great value as regards the lines of management that would be applied for teratoma. The color Doppler can provide us an idea about the extent of the feeding vessel. This will be important during the lines of management that we are going to talk now. Next, it gives us an idea about the evidence of arteriovenous shunting, and examination of other parts of the fetus would show us the evidence of fetal anemia, as seen on the right image, in the middle cerebral artery pulsations where the peak systolic volume is high. Here is a 3D picture of sacrococcygeal teratoma, which shows it in a clear way. However, in practice, this modality of imaging has little value in the management lines. But if we look at the 3D slicing view, multi-slicing of the picture can provide us a very good idea about the type of teratoma, whether it is external or part of it is internal, and if it is external, about the size of the pedicle that attaches it to the sacral area of the baby. This would be of great help during further lines of management. Now, what about the management? Actually, sacrococcygeal teratoma, whenever it is cystic and of significant size, can be drained, and this is a simple way for management, and this can help to decompress the high pressure of the uterus and prevent further preterm labor. For solid teratomas, actually, there is nothing much to be done if the patient is approaching labor. Better than to consider the early delivery and to submit the baby for postnatal surgery. Cesarean section is indicated, of course, for most of these fetuses to avoid the trauma to the tumor or to the fetus in labor. There was a line that started by the year 2011 and still in some centers it's used, is targeted ablation of the feeding tumor vessel using radio frequency ablation for the pedicle of the teratoma. This blocks or destroys the communication between the teratoma and fetal circulation. As you see, the needle is inserted inside the teratoma in close proximity to the feeding vessel, and multiple ablation cycles in multiple settings can be done. If this is done well, it can be reflected on the middle cerebral artery, peak systolic volume, and on polyhydramnios. Both can be improved and normalized in a good percentage of these cases. Another line which seemed to be of better reproducibility and better results is the intrauterine laser ablation of the feeding vessel. As you see in this picture, there is a sagittal view that shows a large solid teratoma. In the above picture with wide pedicle, and in the picture below, the arrow points at the dilated inferior vena cava, while the middle red picture shows the size of the teratoma, which is about more than 1 liter of volume. In this case, you can apply the laser ablation to the feeding vessel, guided by the color Doppler ablation, and this leads to the same results, but may be easier in use, better than radio frequency. Now we come to the end of our lecture today, and hoping to see you next week to talk about other fetal tumors. Thank you and bye-bye.